Hello, everyone. Good evening. I hope you can hear me loud and clear. I'm
Yeah,
Diptesh Malik, Marketing Manager for Mindray India. I'll be the moderator for today's webinar. So, as COVID 19 is rapidly evolving and spreading globally, we think it is Mindray's honor and responsibility as well to establish a platform for all the international communication to happen among clinical experts from different countries to better fight against COVID 19. Today, it is our great honor to have two panelists sharing their keynote speeches with us. Firstly, Dr. Zhiyong Peng, our guest speaker from China. As introduced by my colleague Fiona, he is a professor of critical care medicine and anesthesia, director of ICU of Zhongnan University at Wuhan University, Zhongnan Hospital at Wuhan University. Dr. Pong has been fighting COVID 19, handling this extraordinarily challenging situation in the past 4 months, right at the epicenter of the pandemic, that's China. With great efforts from the frontline clinicians, including Dr. Pong, China has now seen a large decrease of new cases now. Welcome, Dr. Pong.
hi, hello, good
Hello.
afternoon.
So, Dr. Pong is electing chairman of the critical medicine branch of Hubei Medical Association. He is a member of Society of Critical Care Medicine of USA since 2007. He is a member of American Thoracic Society since 2006. He is a member of European Society of Anaesthesiologists since 2002. He is VP of Hubei Province, Chinese Society of Critical Care Medicine. He is the General Secretary for Critical Care of Chinese Society of Anesthesiology as well. He is the Board of Editorial Member for Journal of Critical Care USA. His areas of special interest include critical care and anesthesiology. He has more than 30 years of experience in healthcare now. He has written abundantly around publications of more than 100. He has achieved an award which is Star Research Achievement Award awarded to him by Society of Critical Care Medicine under US mentorship. He also received an annual award from Society of Critical Care Medicine USA in 2009. He has received the prestigious Harry M. Vars Research Award by Aspen USA. And he has also been awarded the National Excellent Science Books First Prize Award by China 1996. Welcome. Welcome, Professor Bong.
Hi,
Also, along with our friend from China, we have very esteemed Dr. Muralidhar Joshi with us. I take this opportunity and privilege to introduce Dr. Muralidhar Joshi, who is the National President of Indian Society of Anaesthesiologists in India, which is now ongoing. During this COVID time, especially in India, Dr. Joshi is actively taking part in formulating the SOPs, work guidelines, protocols, and various directives for World Federation and ISA. Welcome, Dr. Muralidhar Joshi.
Thank you. Thank you.
Yeah. So, Dr. Muralidhar Joshi is the head of Department of Anesthesia and Pain Medicine. Also, he is the director of Pain Management Center at Virinchi Hospitals, Hyderabad, which is in India. As I said, he is the national president of Indian Society of Anaesthesiologists in India. He is the GC member of WFSA. He is a member of WFSA Pain Relief Committee for the past 4 years as well. He is the ex-board member of Asian and Australasian regional section of WFSA. He is a ex-sub-editor of Pain section ATOTW. In 2015, he was a part of WFSA in this regard. He is the honorary secretary of Indian Society for Study of Pain, ISSP. He is the honorary treasurer of ISA. He is the reviewer for various national and international journals as well. Dr. Muralidhar Joshi's areas of special interest include pain education and interventional pain management. He has total experience of over 25 years in healthcare now, glorious 25 years. He is the author of 6 books, many articles, some books which include fiction as well. He has been instrumental for the first Android application development on interventional pain management. He is the first to start fellowship in pain management in India. He is the first to author a textbook of pain management in India. He is the first to start e-learning in pain management in India. His one of the highest awards is the Academic Excellence in 2010 by the prestigious body of ISA India. Welcome you, sir.
Thank you, Marich. Thank you.
So over to Dr. Muralidhar Joshi now for his presentation of today.
Okay. Yeah, this is the very good question. Uh, actually, we run the screening test for the for the COVID-19 for all the patients, whether or not they are elective cases or they are emergency cases. We run the the test, including the PCR, including the serology test, and we will try age. But we are try age these patients based on the results. So if the patients was considered as the COVID-19, and then we will move these patients to the specific buildings. If the patients is still waiting for the results, and we will put the patients in the buffer area, and to also waiting for the results. And if the patients were now considered as the non-COVID, and we just labeled this patient as normal cases. So based on the results, and of course, we need to run all the screening tests for all the patients.
Okay, just next one, I just want to ask how many beds really they had in that Libya province, to take care of that huge road. That's not a small thing, because subsequently they constructed the hospital and all in 10 days. That's a different story. Can you ask that one?
Yes. So, Dr. Pong, we heard that many new beds were added and some cabin hospitals came up in Hubei province. How many exactly beds were required for such cabin setups, such hospitals?
You mean during the outbreak or now?
During the outbreak, when
Yes,
it all
yes,
started.
yes.
Or during the outbreak? So actually, we have one specific hospital, which is called infectious disease hospital, open only for the for the COVID-19 in the early stage, which is around only 1,000 medical beds. But unfortunately, was not enough for the for the patients, for the COVID-19 patients in the early stage. So we had to open other hospital, especially for the teaching hospital, to take all the COVID-19 patients. So actually, we almost opened to around 20,000 medical beds from the general hospitals totally. And this is only for the patients, which is called hospitalized patients. Also, we opened the temporary hospital for the mild cases, just just to follow up the patients, because we cannot quarantine the patients at home. Because in China, the the apartment is quite small. We have no enough space for the patients to the home quarantine. So we opened the temporary hospital, such as the theater, such as the the sports center, for the for this kind of mild cases. Just follow up, just let them just not allow them affect the other populations. So around about for this kind of the temporary hospital, almost around 10,000 or 10,000 to the 15,000 temporary hospital medical beds in the early stage, during the outbreak.
One last question, Frank, from my side. One last question from my side.
Yeah.
I heard your press statement yesterday. Let me repeat. I heard your press statement yesterday
Mm-hmm.
from Wuhan province.
Mm-hmm.
So Hubei province, about the recurrence of patients, and you had some group and they wanted to do the screening tests for almost, I should say, 1.1 million, something like that.
Yes.
And
Yes.
you said it is very costly, it may not be practicable. That's what I heard. Correct me if I'm wrong.
Yes, because we just
No, I'm not at all. One more thing I want to know is, were the patients same as the previous patients, or are they new?
so actually we found I think we found 6 new cases just in the last 2 days. So this because all these cases, new cases, were mild cases. So we are still in tracking the people probably they have which have the close contact with these new cases. So from this point, so the government finally make the decision to run all the screening tests, in this city. So just one by one, just one by one. So first, do the screening test for the high risk of the population, such as the population from the medical staffs, or the family of the family members of the hospital staffs, the family members of the patients, also the or any other or any other population which they have a close contact with the potential COVID patients. So just one by one, just the step by step. So first for the high risk population. So then the government want to run all the screening tests for the whole city.
No,
So we have more than 12 million population in Wuhan.
yeah, Dr. Peng, only one question is, are the new cases what you heard as some so-called positive, are they the old patient who became positive, or the new categories? The new patients, are they the old patients who got reactivated, or is it the
actually all the new cases they have a mild, they are very mild, no any severe symptoms, just just the quarantine in the hospital, for the follow up in the hospital with which is called the Zhongnan Hospital. This hospital is specifically for the infectious disease patients.
That's good. Thank you so much. Yeah.
Okay, thank you.
So, Dr. Peng, if you have any questions for Dr. Joshi
Yes.
and India specific, yes.
Okay. Thank you, Dr. Joshi, for your excellent talk.
Thank you,
So
Dr. Peng.
actually, I'm also concerned. Probably after the COVID-19 outbreak, everything will be changed. In our, not only in our routine practice, but also from our routine social life. So do you have any experience, in your hospital? So how do you triage your patients daily? So such as because you have, for example, if you have the emergency cases, how do you triage this patient is COVID or non-COVID? So if and how do you make the decision? So how do you put the different patients in the different facility or in the different building, in the different ward?
Thank you, Dr. Peng, for information, and thanks for your excellent lecture. And also, we learned a lot from what you went through at Wuhan. In fact, what we are observing, the difficulties, what you faced, and also that was yours was the first exposure.
Yes.
Wuhan was hit pretty badly. Let me put it. It could be me, it could be you, it could be the panelists who are sitting here. And you handled it to the best of your capacity and your understanding of the illness, what was happening, nobody knew, what was hitting whom, why. So with all those things, we learned now the question strategy, what to be followed the hospital is. Don't ignore any complaints, because At that time, when probably this was about 4 months back, the thing was like I thought it could be predominantly aerosol kind of thing. At that time, I don't know about that's what we heard from the initial inputs what we got and all. It could be aerosol kind of thing, like from the whatever the there a lot of discussion from where it came and all those things, and back to human and all those things. Initially, it was projected like a aerosol. Subsequently, they said that the virus is found in even probably in the GI thing also. Then they said the peritoneal fluid also. Then somebody said CSF also. Then it became like it can come from so many places. Doesn't have respiratory pathogen. It was projected like respiratory pathogen, but it not separate. So now what any patient who comes and probably you look at it because the incubation period they said 1 to 14 days. So technically, most of the people they know about it because like India is still under lockdown. Like we don't have we do not have the full population who has come out of the whole lockdown coming to the main circulation. But still, we are watching what are the variations which are there, and probably one thing we did not get much information from Wuhan. The thing is, two groups actually kids we did not know how is it they are presenting at Wuhan, and pregnant women difficult. I'm not expecting that we wanted to know from there, but predominantly it was more like aerosol kind of thing. The people took precaution. Now what we do is we look at the probably who showed symptoms and all those things. Taking biggest problem is the limitation of getting the testing kits. And suddenly somebody and false negative is almost 30%. That's what we say, RT-PCR. If false negative is 30%, then we have to look at if somebody negative today becomes positive 3 days from now. How do you take it from there? So still we are. I would like to say the lockdown phase we are coming out on all. Actually now we are looking at like easing of the thing, and probably the kids are more. These 4 months, probably I should say the classical from Chinese saying, the bamboo tree doesn't grow tall initially. First 4 months it develops only its roots into the soil. Subsequently the tree grows. So first 4 months India was doing same thing, allowed the roots to go in deeply with all the experience. Now we are looking at it can present in different ways and all. We take it, we respect the way it comes. And what I look at is at this point of time is treat everybody as suspect COVID. So there is nothing like stigma kind of thing about that one. Like suspect COVID, and it can present in diverse way, educate the people, and take it about. And it's not like it's not like pathognomy compared to HIV, HPV, like lifelong stigma and all those things. You just have to tide over the case. That's why I asked you the question about the new patients. What you had at probably South Korea and maybe China. Was it a recurrent second wave, or was it a new group of patients? Because I studied one more thing from China that I don't know, maybe you can correct me, maybe I'm wrong. When you had the first patch, maybe earlier, maybe I don't know, October, November, something like that. This all from what we read from the WhatsApp knowledge. It could be wrong. 99% is wrong, 1%. And I believe apparently the virus was injected into some monkeys. Same virus, what we got, human got affected. It might be wrong, but the thought seems to be good. And after 14 days, maybe some of them they died, some of them survived. Who survived after 14 days? One more inoculation was given. But this time they had a very mild. After 14 days, one more inoculation was given and all. So, idea of asking was whether the patients who got reactivation, so secondary wave what you got, was it with new patient or old patient? Was if new patients they got it, then we have to look them at a new group. If it old patient who got it, in case they showed mild symptoms, that means there's something called herd immunity which might be developing. I'm wrong, you can correct me. Dr. Peng, your thoughts?
Sir, Dr. Joshi, I think Dr. Peng, yes, will continue. There was a specific question, triage.
Yeah.
How are we going to adopt in emergency the triage specifically? That's
triage point of view, it all depends. What we are following in India right now, like now, we are also almost now, for example, India recorded its first case in, I think it's on January 30th, first case we got, January 30th. We went to lockdown around March 24th. You can say almost 2 months after the first case and all. But like what a patient comes and all, like 1 week I got community surveillance also, in which a patient, we have specific COVID hospitals. Once the lockdown announced, all the elective surgeries all the hospitals were closed. Only some hospitals directed only as COVID positive, COVID hospitals, and all the patients were streamlined to that COVID hospital only. So they were doing the trial with respect to depending on symptoms and all those things because the kits were limited. We couldn't expose the entire country for the whatever the tests and all those things. Every city, every town had a kind of a COVID hospital. All the patients were sent to that particular place, and irrespective of whatever the complaints they had, say suspicion of fever, respiratory infection, and subsequently by then we could different symptoms like GI also, or probably primary contact, secondary contact. Everybody was screened, and all the surveillance, and then they were kept under observation. And as per the merit of their complaints and all, they are put on only observation or observation with oxygen supplementation, or with probably with ventilation and all. Probably at the end of all these things, we are sitting around maybe as of today about 74,000. I should say about the infections. About then probably we might overtake China soon.
So actually, in Wuhan, we have the triage policy in the emergency department. So I just mentioned that we have to run the nuclear test for all the patients. So at least for 2 times. So including the including the PCR test, including the serology test. I mean, at least for for the 2 times of negative result of the nuclear test. So after 2 times nuclear test, negative test, and then okay, this patient will be clear from the COVID-19. So and during this process, we set up the translational zone in the area, support this patient in this area, and we set up the all the PPE, all the policy. So we consider this kind of patients as the potential COVID-19. So after we got the result, and then we will triage to the different area for the patients.
Dr. Peng, I fully agree with you because luckily for us, probably the Wuhan province was the example for us. Already he had done the groundwork for everybody on this planet. So our job was only to follow or modify whatever we can add and all. So before even it came to the India and all those things, so most of the places already we had a COVID hospitals or dedicated hospital or this thing. The triage very clearly who is positive, who is negative, who is suspect. So it was kept separate, like who could be suspect and who could be positive, who could be severely, who might somebody might present like a SARS kind of thing, SARI kind of thing. They might just come like that. So on that basis, people were kept on segregating, but it was kept on under observation because we are getting new information from other countries also. By then, Wuhan had slowed down, and probably the other countries like Italy, Germany, France. So they were in their thick of action, and the presentation was slightly different. We had some people coming from outside the country, like our own, I should say our own countrymen who came from other places because they had gone a job or something. That's fair enough. Nothing wrong about it. But every patient who came and all those things, water complaints they had, the biggest problem sometimes what happens, because of stigma, some people did not tell they had this problem. That's what I told in my lecture, about that one, with smallpox, this was not a problem because it was obvious on somebody's face. The smallpox person couldn't hide his face, but probably I should say COVID-19 person, he can be asymptomatic carrier for 14 days or 10 days, whatever. The smallpox person, no, it was obvious on his face. That's why we could. So quarantine was quite successful in smallpox and all. But here, in that comes to this particular asymptomatic. Now, what do you do if 85% people asymptomatic people will get infected? 85% they recover. Another 10% they might go to hospital. They might recover. 5% might require ICU, or 2.5% might die. So it's very difficult. This is more highly infective. So less I should say about like moderate point of view, but compared to what it was 100 years back in 1918, where loss of life was different, but now 100 years down the line, we look at every life is very valuable. We can't afford to lose any life. So that is the whole strategy, what it changes. But we are not still out of all this thing. We are still understanding the pandemic as it goes. It takes 2 to 3 years. I told there may not be safe exit for any of us. It could be messy affair and people might just come out on the street. Look, let me accept whatever it is. But even a vaccine, one more thing, Pang, I just want, even vaccine has to come, it has to take at least 1 to 1.5 years to complete whatever trial that might be required. I think so. I think so. I think so. What about the medication? Any medication you think it made a difference for any of these patients? Peng?
So actually, from my experience, I don't think so. Is any medication useful for the for this virus, for the SARS-CoV-2 virus?
Vaccine? Vaccine?
Yeah, vaccine probably, but we need to wait at least one year.
So my take is it might take at least another 2 to 3 years. Is it yes or no?
But but probably
Overall, things to settle down.
Yeah, probably the virus always mutated, always changeable. So it's you cannot guarantee the vaccine how long the vaccine will works for the patients.
It's tough, Peg. It's tough. It's not so easy. I know I'm sitting as a critical care chief over there. It's not that easy.
Not easy
for you.
Not easy. So do you think the hot weather can cure the virus?
Peg, actually, weather-wise, it has not made difference. One thing. Let me put it other way around. As I'm seeing it now, or probably rather, like listening discussion and all. Like there are some countries who never had this quarantine. You know about that one, like Switzerland. I think probably. Correct me if I'm wrong. Then in Switzerland, but they opened and they allowed it to happen and all. I think all the countries are following so-called lockdown on the basis of at what time they can really handle the pandemic in a better way, because they like ramp up the health infrastructure and the people, beds and all. On that basis, we are increasing the lockdown, not just because we want to increase lockdown. Lockdown is morbidity, is the question. But question is it what every country is looking at it, how best they can handle that particular one. But Switzerland is managing, and some handful of islands in Pacific. You know it much better than me, close to Australia, New Zealand, and they don't have a single patient.
Okay.
Peng, I have a different question for you.
So
I have a question. You're not over.
Yeah.
About air conditioning. What do you think?
Air conditioning. So
Yeah.
actually we turn off the air conditioning, for the during the outbreak of the COVID-19. So because this is the potential resources for the transmission. Yeah,
Peng, one more thing I want to hear from you. What about the scavenging system from the operating room? Scavenging system. You're an anesthesiologist. I'm exploiting completely. I'm exploiting you. You're an anesthesiologist. What about scavenging from the OT? Can you use central section, or you want it to modify?
You mean for the in the OR?
Yeah, absolutely. Don't tell me I don't know. You're an anesthesiologist.
Yes. Yeah. Yes. I'm an anesthesiologist. Yeah.
Yeah. Now, what about air conditioning? Do you want a negative pressure or a normal pressure?
Yeah. I mean, if the OR can equip with the negative pressure, probably it's okay. For it's good for the for our medical professionals. So I actually I highly recommend in the way it is to prepare one room of the OR in the OR for the COVID patients with the negative pressure.
No, Peng, I have one solid question for you. The question here is, we probably both of us working in some institutions. We are lucky. Say I have 10 operating rooms, I can spare 2 operating rooms only for COVID work. In the small unit which has got hardly 1 or 2 theaters, how do you guide them? What they should be doing it? Air conditioning and scavenging.
Okay, sorry, I cannot follow you.
I'll tell you again.
Sir,
You and me are big hospitals.
Yes. Because
we can spare 2 operation theaters for something. COVID-19. Only COVID-19 cases will be done there.
So anyone?
So Dr. Peng,
Yes.
if I can intervene, Dr.
Yeah,
Joshi is
please.
asking. Yeah.
Yes.
So Dr. Joshi is asking
Yes.
if we are all in big institutions, like Dr.
Yes.
Joshi is working in a big hospital, you are
Yes.
also a part of big hospital.
Yes.
Can we convert the whole hospital into a COVID-19 setup?
No. No. No,
Okay.
because we just open one building or open two buildings for the COVID-19 patients. So we need to keep other buildings for the non-COVID patients. So and because in our hospital also we just one of the biggest hospital in Wuhan. Also is the teaching hospital from Wuhan University. So during the outbreak, we opened almost half of the facility, half of the buildings for the COVID-19 patients. Also, we keep other half for non-COVID patients, where everything totally totally separate from the COVID and non-COVID. So including all the including the the CT, including the lab test, totally separate. But we cannot because we have to serve for other non-COVID patients, even
Yes.
during the outbreak of the COVID-19,
Yeah.
especially for the emergency cases.
That's great, Peg. Yeah, Diptesh. Yeah, please go ahead, Diptesh.
Right. Sir, did I understand your question right, Dr.
No, that's
Joshi?
okay. That's fair enough. That's fair enough.
Okay.
They are different model. Yeah.
Okay. So I believe we after this discussion we can again come back to similar discussion. I have a few questions already ready for Dr. Peng and Dr. Joshi.
Oh, great, man. Ah, please go ahead. Yeah.
Okay. So first question, I believe Dr. Peng, there is a lot of interest from Indian audience about China for obvious reasons. And same thing, I believe from audience in China, we can also see how Dr. Joshi can take up about the matters which are there in India now. So on similar lines, I think the first question to Dr. Peng is, does the BCG vaccine have any protective qualities against COVID-19?
So actually, I heard that story because I heard the different population infected in the states. The told us. So some Asian population, especially the Chinese immigrant. So actually, the instance of the COVID-19 in the states, from the Chinese immigrant actually quite lower, because they calculate probably this Chinese immigrant they have the the vaccine when they were in China. So I think probably this will boost the immune function to against the for the COVID-19, but we have no any strong evidence to show this relationship, because in China everybody have this vaccine already, but we cannot compare. But in the States, actually, they do have the data. They told us the Chinese immigrants probably the instance is quite low, because they have such the vaccine before. Probably I cannot show this is the relationship, or this is the any other because we have no solid evidence to explain that.
Okay, I understood. I think it's a US thought that probably BCG is helpful, but we do not have scientific evidence to prove. Am I right, Dr. Peng?
Right. Yes.
Okay. So next question is to our Dr. Joshi. Uh,
Yeah,
so,
Diptesh.
sir, when should we start the elective surgeries now? In India, the situation you know. So, elective
Oh, yeah.
surgeries.
Yeah, sorry. Peng, anything?
No, sir,
Peng,
you can
anything you want to
continue.
add?
Yeah, Dr. Peng, if you want to add anything.
Yeah, you mean when should we resume the elective cases, right?
Right, right. I'm asking this to Dr. Joshi for India, when the elective surgeries can start. Yeah.
So actually, in Wuhan, we started the elective cases just in the early April, because during that time, almost zero new cases for for almost 2 weeks, and then the hospital authority so determined to resume the elective cases during that time. But this is a very difficult stage, difficult time. So we need to prepare for all, to reopen the elective cases. So first, we need to clean everything to prepare the environment. Also, we do we set up the policy, the protocol. Just we mentioned how to triage the patients based on the results, based on the PCR result, based on the serology result, because this is quite important. When we determine to open the elective cases, we need to we need to do the best job for the triage for the potential COVID-19 patients.
Yeah, thanks, Dipesh.
Sir, I think you can also continue. Yes.
Yeah,
Thanks,
yeah.
Dr. Peng.
Thanks for paying. Actually, what I can understand, what I know about that also, I think Wuhan was under lockdown for 76 days. Am I right?
Yes, yes,
That is that you finished on April 6th or 8th,
yes.
right?
We almost
April
resumed.
first week you said April 6th or 8th you finished. I remember.
Yeah,
Then you start electives.
we resumed the elective cases for almost 1 month.
So actually, what is being actually suggested by the different, probably I should say, with the societies across the globe is, what is at least 14 days should be there, where there is a dip in the number of the the incidence of the patients or the death, whatever you say, like number of cases or deaths and all should plummet continuously for 14 days. That means you are going down probably, and all those things, the pandemic is slowing down, and that is the time they say you can go for the elective one. But again, there is one more thing is a lot depends on your authorities, because sometimes you lock down, as long as you're on lockdown, things are fine. The moment you open it up, again it opens up. So the having said that, but does it mean that you can have been locked down for 6 months or say 1 year, 2 years? It won't work like that. I think electives, best thing is, what best suggested technical and medical point of what we can suggest is 14 days continuously. If the numbers are going down, death or the new infections, that's the time to start the elective work. Dr. Peng, anything you want to add?
Yeah, so actually, why we choose the early April for the day to reopen for the elective cases, because during that day, almost 2 weeks, no any new cases. So this is the government, the hospital authority, they have the discussion with the expert and to determine, okay, that time we open the elective cases, probably is the relatively safe for all, for the patients as well as for the medical workers. And also, of course, we need to prepare, for the reopen the elective cases. We need to prepare. We need to the policy. We set up the protocol, because we need to do all the screening tests for the patients.
Yeah, I really noted your thoughts on all those things. As probably, I think probably what we are watching, like the AC recommendation across because I think the best authority will be the local authorities. They know how many kits, because it's not only about the 14 days from the country dipping and all. You have to know how many ICU beds you have got. You have to know how much is the manpower. You have to know how many PPE kits you have. Can you take care of all those things? And in case if you require the COVID testing and all, or equipped for all those things, then you need to have the priority whether you want to go for the transplant patients or you want to go for the like cardiac surgical patients or oncology patients. There are so many factors which are involved. But one simple thing guideline is like if resources are optimum, then you can go for the elective work. The reason being why you can go elective but later date, only reason being the outcome has been for people who are COVID positive. As of now, but things might change because as I told in my lecture, 14,000 papers have come in last 4 months. Even one person sits in one paper per day, he is going to take 1400 days. Let me correct myself, 365 days in a year. So that almost comes to a, you can imagine how much of time he is going to take like for 365 days in a year. If you 14,000 papers, so much of information. Safest bet, government and available resources. If you are comfortable, you want to start, make sure the COVID testing is available. And if you don't COVID testing enough and all those things, have enough PPE kits. Test kits are available. Get it done. And then if it's positive, let them go through cycle of recovering, going through all the quarantine and all those things. Then you can consider for the procedure. Dipsat, did I answer your question?
Yes, sir. I understood. Like if the resources are there, as per Dr. Peng and Dr. Joshi,
Yeah.
then we can start the electives, and probably after a time of 14 days under observation, if the government decides so.
Yeah.
Yeah.
Oh, yeah. Everything's okay. Your resources okay. Your should be make sure the patient is safe. Make sure
Correct.
the medical workers enough they have enough energy
PPs.
to take all the
Correct.
patients.
Correct. Okay. So next question to Dr. Peng. Dr. Peng, how about the reinfections which have happened to the patients who got infection first time, and then probably the reinfections happened? What are the effects of antibodies, and what is the duration after which this reinfection usually happened?
So first we need to define what's the definition of the reinfection. So if the patients only have only like the 1 or 2 times of negative PCR, and then have the one more positive PCR. So we don't think this patient is the reinfection. So because probably the one negative PCR probably is the false PCR results, not the true PCR. So if the patients have the at least 5 times negative PCR for a long time, for example, for almost 1 month, and then when the patient came to hospital again, and then they do the test with the positive PCR, and then we consider that patient probably is the reinfection. So this is the different definition, very important, and also how we manage the patient with the reinfection. So just to follow up the patient, most of the patients with the reinfection, of course, the instance of the infection is quite low. I cannot say how much but from our hospital data, probably is around 2% of the patients, probably have the reinfection. So, and also we follow up this kind of patients as almost all the patients, just the mild symptoms or asymptomatic. So we just follow up the patients. Every 2 weeks or every 1 month for the nuclear test to see how the patients the nuclear test changes, or any serology test or any antibody occurred. So just the follow up of the patients, and from the data from our hospital, and I think it's some of the patients with the reinfection gradually they become elective, become elective again. So without any treatment.
Okay. Okay. So next question is to Dr. Joshi. Uh, Sir, in India,
Yeah.
what are the new social and emotional problems for healthcare workers, especially in these tough times?
Not just, I think India, it's across the globe. I think Pengil also will agree with me. See, the question here is just imagine healthcare worker goes to a hospital. Just imagine, like they're probably slightly more knowledgeable, definitely, than compared to the common civilization. You locked down, you go to the work and all. Now you don't know whatever the gloves you're wearing or probably whatever mask you're wearing, it's giving complete seal or not, you don't know. Because I think Peng will agree with me in Wuhan itself. Peng, am I right? If you correct me if I'm wrong, almost close to 2,000 people we lost health workers at Wuhan province. 2,000 health workers we lost because we didn't have the safety precautions and all. Either they did not follow, or there was some lack or overworked. A lot of them, they made a lot of efforts at Wuhan. Until that was the, I should say, the incubator for everything. Almost 2,000 people lost their life because they wanted to help the patient, save the patient. In the process, they got infected and they lost the healthcare personnel. Same thing applies here, because you come to the workplace and you wear the whatever the doffing or whatever donning you want to do, what are the mask, what are the hand wash. At the end of the day, you don't know have enough hand washing properly. Unknowingly, I have touched my mask, and I don't know I have touched my phone. And when I go back home, maybe I won't hug my children, and probably the children might get infected, my family might get infected, and this is human. I don't say see, people have worked in probably kind of war, epidemic kind of situation. War is different thing. Understand, like in a person world war between two countries and all the same people die because of the hemorrhage or maybe fractures. A lot of these things. The infection something at the end of the day, if the person has to go back home, his worry is, am I carrying infection back to the home? One, at here workplace also they don't know. And second thing is how we as hospital or healthcare professional we treat a healthcare worker who got affected with the COVID. Like if I get a COVID-19 infection today, say for example, how will my hospital take it? Will we take it? Look, this is occupational hazard. He has taken it. Will they take care of me? Or say no, this is not proper care and all those things. That's why I got suffered. The fear is there because across the globe, the fear is the loss of job, a loss of esteem, and loss of family life, and it is not, it's human. Nothing wrong about it. Nothing wrong about it. We have to address this thing and keep on talking to these people. It's not question of doffing and donning. It's always question of what we call it, talking to them, like tender loving care. Like talk to them, say hello to them, and it's nothing wrong. Like you're not going to die, nothing like that. It's just infection. It comes and it goes. This reassurance almost we'll have to repeat on day-to-day basis. That's the only way we can motivate our healthcare personnel who are working with us. Yeah, Deeptesh.
Okay, understood, sir. One question to Dr. Peng. So, any comments on the role of supportive treatment in ICU, like CRRT, cytokine removal, pharmacotherapy? What is the role of supportive treatment in ICU?
I mean, for the CRT, so actually the instance of the AKI from COVID-19 is variable based on the different region. So actually in Wuhan, the total instance of the AKI from the hospital around less than 10%. But for the ICU, the AKI instance is around 20%. So about half of the patients with the AKI requiring the renal replacement therapy. So I do think that kind of therapy will works for the patients with COVID-19. And also regarding the cytokine removal. So this is based on the theory of the cytokine storm. So if the patients have the rapid changes of the peripheral lesion, such as the rapid deterioration of the oxygenation. Also the patient with the complicated with the shock or complicated with the multiple organ failure. And also we have a lot of the diagnostic approach to detect if the patient have the cytokine storm or not. So if the patient have the cytokine storm, the patient usually have the elevated ferritin. The patient have elevated IL-6 level or CRP level. And so in this situation, we may have some approach to remove the cytokine. So one approach, which is called hemoabsorption or hemoperfusion, which is the using a column with containing the absorptive materials to remove the cytokines. So we use the such as the column from the company from the Europe or company from China, and also we run some study. So it do reduce the cytokine levels, also to improve the organ function. So this is the one approach for the cytokine storm. Also, we use the monoclonal antibody to control the cytokine storm, but from the data, so probably we haven't seen any improvement regarding the monoclonal antibody for the cytokine storm. Also, we can use the corticosteroids for the cytokine storm, but also we have run some study for this kind of approach. It works for the cytokine storm using the corticosteroids. So this is the our approach, for the different supports for the patient in the ICU.
So, Dr. Peng, my next question to you is, according to a recent UK report, it is suspected that there is some connection between COVID-19 and an unusual inflammatory syndrome in children in China. Any thoughts on that?
So, actually, we this kind of cases are rare. Most of the pediatric cases, they have the complicated. I mean, not only for the pediatric cases, but also for the adult cases, or complicated with the embolism, the vascular embolism. So, for the for some pediatric cases, they have the pediatric, they have the embolism, in the big vessels, and probably they will induce the sudden death for the kids. So this is the big issue. And so because for COVID-19, the hypercoagulation status is quite often in all the patients. So we routinely using the prophylactics heparin for our patients. And if the patients have the high risk of the coagulation, such as the dimer is quite high, and the patients have the DVT, and probably we use the therapeutic dose of the heparin for the patients. So I mean, this is the vascular embolism quite often in the patients. So you mentioned that for the kids, I know this kind of problem is I heard this story happened probably happened more in the States, happened more in the in the Western countries, but in China, because this kind of situation probably not so often, but we do have such as the vascular embolism problem in all patients, in all ages of patients, not only for the kids, but also for the adults.
Okay. So, sir, next question to Dr. Peng is do you think the serum ferritin levels in COVID 19 patient is an early clue for COVID 19 infection?
Uh, I don't think it's only clue because the PCR, for the nuclear test, the PCR positive is the one of the clue for the COVID-19. So of course, if the patient have the positive IgM or positive IgG, which also indicated that the patient infected the COVID-19 already. So they have the curve, the curve, based on the time course or of the PCR, when the PCR occur, when the IgM occurred, when the IgG occurred. Usually the PCR occurred earlier, and then the IgM, and then the IgG.
Yeah, okay. Uh, Next question is in big setups, hospitals can dedicate operating rooms for COVID 19 patients. But what about small hospitals? They have very limited operating rooms. How can they dedicate those resources for COVID 19?
This is the big challenge for the medical workers in the small hospital. So I mean, depends. So if it was the it was the outbreak time, probably just shut down all the routine cases, only for the COVID cases. So I mean, if it was just like our situation in Wuhan, as probably the small hospital only focus for the non-COVID patients, but they need to run all the screening tests for the patients.
Okay. Next question is how is the condition in Wuhan and Hubei province now? Because in news, people are seeing that there is some sort of reinfection. Also, there is some positive news that many people have been treated. So, from your view, how is the situation exactly in Wuhan and what can be the future situation?
So actually now the situation in Wuhan I think is almost back to the normal, because all the the hotels, the restaurant reopened already, and just yesterday we have some new cases, just 6 new cases. I think it's the new case less than 10. It's normal, for the Wuhan, which is a huge population. But if the new cases is around more than 100, and then I will suspect that probably we need to reconsider do we have something to can improve the situation better. But if the new cases less than 10, I think it's normal. But actually we have very strict policy to quarantine all the all the citizens in Wuhan. We have very strict policy, in the public places. Every public places, we need to have the temperature check. We have to show the green card. We have to show the health card. For the to if we want to go anywhere, we have to show the health card, which is containing the information. How is our recent nuclear test, how is our recent serology test. So if you have the healthy card, you are allowed to go anywhere. I mean, so and even in the public places, they have everybody have to have the temperature check. So all those policy make sure we have to control the new outbreak of the patients. So actually, in the Wuhan has reopened already for 1 month. So I don't think it's we have the second wave of the outbreak.
Okay. So next question is, as an ICU intensivist, what do you think of the current situation now? Is it early intubation or delayed intubation with oxygen therapy, which is better? Early intubation versus delayed intubation with O2 therapy.
So I mean, it depends. It's the whether or not we will perform intubation for the patients. We need to. I just mentioned that we need to run the screen test for the patient. So if the patient is long COVID patients, and then we just follow the protocol for the long COVID patients. So if the patient is okay, and then we can whether or not if the patients suitable for intubation, and we have to intubate for the patients. So we cannot delay the intubation for the patients. But of course, we need to prepare the minimum protection. I mean, the N95 mask is the minimum protection for our medical professionals. So if you want to perform the intubation, also you need to wear the goggle, as well as the probably the eye shield during the procedures to prevent the potential infection, even the patient is diagnosed as long COVID.
Okay. Next question is around ECMO. So how exactly ECMO helps for patients who are positive with COVID-19?
So from our experience, ECMO, the mortality from the ECMO treatment for the COVID-19 is around 50%. So almost similar to the patients with the severe pneumonia, with other virus pneumonia from other etiologies. So, I mean, the main point is that we need to initiate ECMO a little bit earlier. So if the patients have the severe hypoxemia, and also complicated with the carbon dioxide mutation, so we need to initiate the ECMO for the COVID patients. So I don't think it's any differences from the ECMO treatment, from other, long COVID patients.
Okay. Some people feel, there is a comment from some doctors that propofol needs to be used very less for COVID-19 patients. What is your thought on this, Dr. Peng?
So propofol also even for the intubation, we should be careful, because I just mentioned, from my talk, propofol will worsen the hypotension because during the intubation, most of the patients are complicated with the hypotension. So we need to minimize using of the propofol for the patients. And also for the patients, for the sedation, also we especially for the patients have the using the the nutrition, the non the PN nutrition, and also we need to take to consider the propofol will increase the fat contents.
Okay. Sir, one question from non-COVID patients. In Wuhan, during the peak, definitely it would have been the COVID cases which were getting treated. But was there also a possibility that non-COVID cases also came in your ICU or in your hospital?
Yeah, of course. Yeah, during the outbreak, we have the different building for the COVID and non-COVID patients. So even we have the ICU. Each building have their own ICUs. So yeah, we definitely we need to triage the patients in the COVID patients in this building, non-COVID in another building.
Okay. So, Dr. Peng, I believe it's quite late as you informed me. If you have any questions to Dr. Joshi now, you can ask, and then we will continue the session with Dr. Joshi. For our Indian audience, it is not very late now, but I believe in China, as you texted me, it is getting a bit extended, right? So,
Okay.
Dr. Joshi, please unmute your line, sir. Uh, we will have some concluding discussions between Dr. Peng and Dr. Joshi now, and then we will request Dr. Pengs for his kind advice further.
Yeah, it's nice talking to you and I would love this probably this we could have ended like we completed this session for some more longer time, but in a time frame is something and all. But we are learning from your experience, but we hope you don't have this experience again and again. It is the last one. At least within our generation, the next generation plan the way they it want to do. And any probably you want a clinical pulse you want to share with us like do's and don'ts. We always welcome you. Please share with us so that we don't do that mistake and then try to learn. Rather, we learn from your experience. Yeah, Peng, please.
Okay. Okay. Thank you. Thank you.
Thank you, Peng. Thank you so much.
Thank you.
Thank you, Dr. Peng. I believe this was an informative session for
Thank
both
you,
of
Peng.
us.
Thank you, Peng. Thank you. Thanks
Okay.
a lot.
Okay.
Thank you.
Thank you.
Yeah.
Okay.
And we will continue the session now with Dr.
Yeah.
Joshi.
Okay.
It was very informative, Dr. Peng, from your side. We heard
Okay.
a lot of new things from ICU's point of view. Thank
Okay.
you.
Okay. Thank you. Bye bye.
Bye
拜
bye.
拜，洪瑞，谢谢，
Bye bye. Thank you.
拜。
Yeah.
So sir, we already discussed about the social and emotional problems for healthcare workers.
Right.
Now there is a stigma as well around healthcare workers, people who are going to hospitals for their regular job. How can India really come out of this notion of stigma, and what is your direction of thought?
This is see the question here is being healthcare industry or otherwise also we have to understand it's part of the game. So look at try to understand about the fear. The fear with respect to it's not a stigma kind of thing. The fear like I might contract some infection from you, and a similar kind of thing. We had this problem with respect to HIV HPCG earlier about the nihilistic injuries and all. It took some time to get over. And if you really want to be much more clear on all those things, like we had Ebola recently, as recently as about 2013, something or 2014 kind of thing. There's some one patient. Sometimes, like what happens, even the color of your skin also might attract other person to think that. I think my audio is low. That's what is being said. Is it better now?
Yes, it is better. I can hear you clearly.
Nandita Mathaput Joshi audio is low. So,
Okay,
nothing wrong about that.
Now she is saying better. Now she's saying.
But okay, fine. Yeah, possible. Now, what I'm trying to say is we have to take it the way it is. I don't think we should find any fault with any person or individual. The stigma is going to be there. Say for example, if we were to be on, say for example, you have a computer with you, or maybe something mobile. I have a computer.
Right. Right.
You have a computer with you, Diptesh.
Yes. Yes. Right.
And
Yes.
all the 14 participants who are there, they also computer mobile with them.
Right.
So why are you having antivirus software with you?
You are right, sir. So to protect
No,
my
I'm not
computer.
right. Who's right here?
No. No. So to protect
Everybody is right.
ourselves.
Everybody is right.
Yes.
Everybody is trying to protect themselves.
Right.
That's human. The
Hmm.
stigma is probably when I'm talking to the Joshis, whatever this thing I'm hearing from you or whatever I'm accessing, so-called the I should say the Zoom webinar or for that matter Mindray and all, it can infect my computer. Yes or no?
Yes. Yes.
So what you do? You take the antivirus protection, or you may
Hmm.
not use the Zoom software.
Right. Right.
So you think anyway different this from the pandemic?
I understand your correlation,
Simple. We
Dr. Joshi,
respect.
sir.
We should
Yeah.
respect. We should
Yeah.
respect. Yeah.
Okay. So, okay. Now, going to the next question, probably a question which is common to many. Will the cost of treatment go up? Because going forward, probably disinfection and all, PPEs, protective sanitization will be involved in everything. So, will the cost go up of
See, the
treatment?
cost is for your safety. You buy a computer, you want your data to personal data to be safe and all those things. For that, you buy an antivirus software. Yes or no?
Yes.
Hello, Pritesh?
Yes. Yeah. Can you hear me? Yeah.
So, yeah, I can hear you. So, question when you buy, you bought the computer and you are installing the antivirus software. Did
Mhm.
anybody ask you to buy the computer?
Probably
So
from my
similarly, if
need.
somebody
No.
goes to
Yeah.
hospital for healthcare facility and all those things, for their safety, because the problem here is the outcome will be very poor if somebody is COVID-19 positive, if they have viremia. For that reason, we have to do certain testing and whatever. I don't know how often you check the your flight bill and all those things. The fuel charge so much, surcharge this much, safety charge this much, and all those things. Same thing at the any hospital. So from where will they manufacture the funds to keep you safe, like so much of gloves, so much of mask, and keeping and all, and extra manpower and all? From where will they provide all these things? See, the people who give a computer to you, you buy a computer
Mm,
X. They say it's hardware only.
mm,
The
mm.
software you buy, software they give. For software you buy antivirus.
Right, right. As per my need, I have to
Yeah, you got a point.
continue.
If I
Mm,
buy a Mindray ventilator, sorry, answer
mm,
workstation, do you
mm.
have to pay for workshop? Do you have to pay for power supply also?
Understood your point. So, as per the configuration
Yeah, absolutely, absolutely.
increases, yeah. Understood, sir. Okay.
Yeah,
Sir, your next point is about telemedicine. You touched upon it during your presentation.
yeah.
What is the future of
No,
telemedicine as per you?
it is going to increase. It is going to increase. The one good thing about telemedicine, whatever we say or what actually I've been using it last maybe 16 years continuously. Nothing less than that and all. It's only for it. It is good for where there is no need for the physical examination.
Right.
History wise, if I can make some like diagnose certain things, certain thoughts and all, it's fine. But if I have to go for the examination and all those things, it's difficult telemedicine. But follow up will be again good. Follow up. Say for example, if I'm a patient of say some clinical psychological problem, something like that, anxiety neurosis, something like that, then counseling on the system is fine. Examination will be a difficult, but one thing we have to understand, Paul, everybody whosoever is still there, is that vitals will be monitored through the newer software.
Mm,
Talk of the
mm.
pulse or respiration or token. It is going to change. It's going to change. And even the blood glucose and all those things for which people have to make a regular visit to the lab, that also
Mm.
is going to change. And in medical supply also, which you go to medical shop and all, like there'll be a drone which will be delivering the medications to you.
Medications. Yeah. So, do you think we are ready for such changes abruptly now? I believe for many, are we ready? Do you foresee us to take this up and accept it as a new normal very soon?
See, the question is the early bird gets the worm. Who is getting the worm now?
Okay.
Got my point?
Okay.
The question here is you have to scale up your investments and your plan and your budgets. You have to put one foot ahead, 1 meter ahead of other people. Be ready for that. I am not ready. Okay, no problem. But somebody is ready.
Right. Right.
They'll walk away with about whatever the credits and all those things. But the question here is it going to make impactable kind of difference? Is the bottom line.
You're right. Yes. Okay. So, sir, next question. Like we see a lot of news that doctors who are handling COVID suspects, they are distancing themselves from their own families. It is really creating a tough time for them as well. I understand that probably they are doing it from safety point of view. But do you have anything as a comment on this?
I think, see, we have to understand the different group situations. Say, for example, if I were to be an army soldier and all those things, I go into the battlefront 6 months, once 6 months or 8 months, I take a break from whatever. If they permit me take a 1 month leave or something, I come back and then spend some time with the family. If things are conducted in the country, if there emergency, then they'll call me back and all. But here also, whatever way it is and all, see, question, this is unanticipated. Unanticipated means there was nobody anticipated pandemic. So these things are going to be that mentally somebody is not prepared. Mentally somebody is not prepared. And say, for example, how many
Right.
right?
Right.
So each war, people have sacrificed themselves.
Mm.
Here also, the only thing is you go to the battlefront, you fight with people. If the bullet hits you, you're gone. But there are people who had only injury to just to make them disabled. Somebody had one leg amputation. Somebody had right hand not working or left hand not working. Somebody had some blood not working permanently. There are soldiers who got injured and all those things. It's not. But question here is, whatever the thing, what it is like in a pandemic conduct, people are not exposed, and that fear is there. Why me only? Why should I be suffering? Why not others?
Okay.
Right? Why not others?
Right.
Why should I be suffering?
Correct. I think it's a mutual thing about
You know,
everyone.
they know it's wrong. We are chosen profession by choice. Nobody forced us.
Correct. Correct.
As simple as that.
Fair enough, sir. Going on, next question is by Dr. Siddha S. Rao. Sir, what is your experience with hydrocortisone and low molecular heparin?
No, I know, Dr. Chakra sir, what is asking is like, it's putting fire and also ghee in same thing. Because the pathology is still varying from, I should say, about where we thought it's only acute viral this thing causing, and subsequently we're talking about what is called as thrombogenesis, and you want to happen for that one, and to open up the thrombosed vessels, and again you want to happen like a steroid, which can create bleeding on its own because stress. It's too early. It's too early for any of us to comment because I told you, even the 14,000 papers are there. It takes some time for a paper to come to compare and contrast. You need to say, one group I give hydrocortisone, one group I give low heparin. Who improved best? To say that you need some control and some cohort. So nobody is sitting here like a Baba kind of thing just to say that like this work that doesn't work. If we knew all those things, probably there are no need for this discussion, this webinar at all. Thoughts are good and all, but I told you 14,000 papers are there. Working about that. A few papers might be supporting, few may not supporting. We have to look at the pros and cons.
Sir, we discussed it earlier as well. Like the virus is mutating and it is changing its form. So some strains are probably more viral, some are less viral. how do you see this? Even if there is a vaccine, probably it will work on few groups of people. It may not be effective as a blanket solution. And also the medications, there is a limitation. So how can common man really try to see a end of this tunnel and see some light of it?
So now you're asking me like a visionary.
Sir, but this question you also, I think, discussed.
No,
with
Deepesh, I didn't know.
Yeah.
In the letter sense.
Okay. Okay.
No, I made a confession at that time. If I knew the answer,
Yeah. Yeah.
I would not be in this particular forum. But let me make it very clear and all. Not to get depressed. Not to get depressed is the bottom line. I would like to say, see, at least now I think, Deepesh, correct me if predominantly we have Indian crowds now.
Predominantly, yes. We have our
Predominantly.
HQ. Yeah. Yeah.
Predominant. I'm not saying.
Yes. Yes.
See, last 2 decades we have surplus food production in India. Let me put it very clearly. And a lot of the food grains are there in here and there, and we are using it for the people and all those things. It's fine. And even the pandemic continues for and all. But I told you, like, the closest family for this one COVID-19 pandemic happens to be 1918 influenza.
Okay.
It took 2 to 3 years for things settle down.
Okay.
Right?
So this is much more dangerous. So
No, not much more dangerous. So that time, people were dying at the age of 17 to 20 years.
Mm-hmm.
What about? Because that people, the life expectancy was much lower. So people are dying at much younger age. Sailors who will go into the sailing and all, and soldiers, they were dying just like that. So it was happening at that time. But took 2 to 3 years. Even though you start working on the vaccine and all, it takes at least, but just think about what it takes about. With the sure farm industry, how much time will it take for vaccine to come? You tell me.
Sir, as you rightly said, I also happen to know that it
Normally,
takes 18 months minimum under trial.
You're right. Minimum is 18 months.
Right.
So what did I say? 1.5 years.
Correct. It's the same thing. So
Yeah.
we have no other choice but to wait, I believe.
About any molecule?
I think many years. It takes
So
many years.
So we are clear about what we're speaking.
Right.
So it took 3,000 years for a vaccine to come for smallpox. Yes or no?
Yeah.
Right?
Right, sir. Understood. I understand your point. So
It's same thing. So question here is, maybe science will evolve, technology will evolve, something new might come. But I'm just hoping, but probably suddenly, unknowingly, probably COVID-19 might mutate into a weaker version. So we might escape. You never know. I'm not saying this is the way it is or that's the way it is. I think all the governments across the globe are working on that one. I think we have to respect their efforts and suggestions, and we have to work on that one. That's the only way we can come out of that one. And probably even individually, if you can contribute certain things, certain way. Say for example, even about safety, social distance, and all those things. It's all buying some time, like lockdown. Till we find a final answer.
okay.
See, that's what it's all said in the battle. Live for a day, so that you can fight it much better next day.
Next day. Yeah.
So live today by maintaining social distance and safety. Probably next day you'll be in a better position to fight again. But don't lose your life. Stay there.
Okay.
Maintain the guard. Maintain social distance. That's the way it goes. No general, no major had an answer for any battle anytime. He said, don't lose your life so easily.
Correct. Just safeguard yourself probably every day.
Dipesh, do you watch cricket?
Yes, sir.
Always batsman told, don't lose your wicket.
Yeah.
Same
Runs
thing
will
applies
come.
here?
Runs will come. Yeah.
Same thing applies here.
Correct. Fair enough, sir. So probably our next question is towards donning and doffing of PPs.
Yeah.
Like people,
That's
yes.
Rajesh Gupta, I think, probably.
Yes. So people understand the different protocols around it. Probably there are many discussions around it already which has happened. But still, as a practice, what do you suggest? What's the best way which people can remember and just follow it?
See, depends. See, where you're working. See, for example, now as of now, at the moment, you are seeing so-called this webinar. I am sitting at my home and having a webinar. So, hats off to the technology.
Correct.
The pen goes probably from his office or somewhere. It's fine. It's okay.
Right.
So if I'm asking certain things about, say, for example, where should I turn it off? If you can afford an office at home, I work from there. If I can't afford an office at home, sit home. So in case they can afford a separate area for doffing and donning, you go there. If not, see, I'll tell you very clear. Dipesh, you have some time? I got.
We have, sir.
So Dipesh, let me very clear. Forget about all the tests and all. Imagine. Tomorrow morning, the first case, whatever needs to be done. Ideally, not ideally. The best practice, which is happening in different continents, is kids are not there. You don't know who's COVID positive, who's negative. Yes or no?
Right.
Surgery has to be done.
Surgery has to be done. Yeah.
So the people are taken to operating theater.
Right.
So everything is so only patient, two anesthetists, or one of the anesthesia consultant, one technician. Am I clear?
Yes. Minimum these people will be required. Right.
So most senior person or most competent person will intubate the patient.
Yes.
They wait for 20 minutes.
Right.
Air is to get absorbed. Then the air exchange. Right?
Yes.
After 20 minutes, other departments will walk in. Surgery and anesthesiologists and all. They do surgery. They get out. These people extubate. Nobody will be there at that time.
No one will be there. Yeah.
After extubation.
Yes.
Right?
So yes.
Take the patient to appropriate area. Suspect COVID positive. That will go there. Non-COVID, it will go there. Next 20 minutes for cleaning and leaving it alone. No case taken.
Correct.
What do you think?
Sir, I think then the OT needs to be shut off, right? Like,
how many theaters do you have?
Yeah, that's the biggest restriction. I cannot.
No, I'll tell you. If you have 10 theaters, this one. Even one theater also. Now you tell me. Dipesh, how many trips you are going to fly in next 6 months from Delhi to wherever your destination?
It's not going to happen, I believe, sir. Now, like, first of all, the service is unavailable, and also then there is a fear factor probably within all passengers that if it is not.
That means your question has the answer for my answer also.
Oh, okay. So I think
people are not coming to hospital out of fear.
Yeah, to the OPDs, the visits must be very less.
They will come. In case I got some tooth pain for last 3 months, I don't mind waiting for 3 months.
Okay. Yeah.
So it's as simple as that. See, anybody has died last 2 months by not traveling?
I'm not sure, but I think not a majority, I guess.
Topic ends there. The answer for the question here is we were indulging in a lot of things for no reason. So simply, what I'm trying to say is things will settle down. See, to take time for 2 to 3 years, not to panic. Things settle down, and government's working, research is working. I got 14,000 papers have come out in last just 4 months and all. It takes some time. Yes, somebody has an answer and all those things to utilize that particular services. You might have to pay the charge. That's a secondary thing. But at the end of the day, I think it makes a sense. Do you really require that surgery, or do you require that hospital follow-up? In case I got the same BP for last 10 years, same doctor I'm going there, it makes me feel better if you go and see him. But that's what I tell you in the lecture also. When I say about like the so-called Hippocratic, the human touch. How the touch now?
The touch is missing. Yeah, the touch is going to.
Not missing. Yeah. It's there. But with gloves.
With glove. Yeah. The healing hands are changed to plastic hands now.
They're tied.
Yeah.
Things will improve of course of time.
Correct.
Not to get worried, not to get scared.
Absolutely. Absolutely. So next question is for emergency surgeries cases.
Yeah.
So any particular screening which needs to be done for the patients who are coming for emergency surgeries to the ERs?
So there is no very clear cut this instructions. If somebody requires emergency, whether positive or negative, is immaterial.
Mm-hmm.
See, for example, I'll tell you, route of action,
Mm.
bleed, hypertension, aortic rupture. Are
Mm-hmm.
you going to wait for HIV, HB stage, or are you going to take up in the OT?
Sir, I'm actually not aware of
You are
this.
not a medical
So
person,
yeah,
I
yeah, yeah.
understand. Because
Mhm.
saving the life is important.
Right.
Who's positive, who's negative is a later story,
Mm-hmm.
right? So same
Right.
thing, emergency itself is a consent for that one, and you presume everybody is like in a positive, viral positive, you won't take up the work.
That way.
As simple as that.
Correct. You mentioned it. I think
Yeah,
let's
also you
assume
have prepared
everybody
for
is,
see because
yeah,
already all the healthcare personnel across the country in India
they are prepared like that.
I'll again and again say they know how to handle infectious patients, especially
Hmm.
NABH certified hospital or whatever this thing there. They know how
Hmm.
to handle HIV, HPV patients. This is
Hmm.
nothing great. Little bit extra response towards anesthetic side because of the aerosol.
Hmm. Hmm. Hmm.
It's very important for us. The aerosol point of view, or about use the box, or use the plastic sheets, or use the goggles, or use the what should I say, the face sheets. It takes some time to
Takes some
understand.
time. Hmm.
You have to give some time.
That's a human psychological aspect as
Yeah,
well. Yes,
nothing
yeah.
wrong
Hmm.
about it. Nothing wrong.
Fair enough, sir. Next question is around use of anesthesia machine
Hmm.
in an ICU. So I believe intensivists are not really comfortable with such short span of ventilation which is provided by anesthesia machines. So in India, uh, what are the practical challenges you foresee if there is any need to use anesthesia machine in an ICU?
So let's say the two things you have to understand.
Okay,
Either
sir.
Muhammad goes to mountain or mountain goes to Muhammad.
Okay.
Am I clear?
Okay. So
If
we
your
have to
ICU,
learn.
if your ICU is full,
Hmm.
the patient has to go to a place where the ventilator is there, and the ventilator is in the OT.
Correct.
You still want an answer, or is it clear?
No, I understood. So we have to learn an upskill. So
Absolutely.
yeah,
See, because and you, what are you talking about? All the newer water ventilators and all, they're back squeezers.
correct, correct,
As simple as that. So why do you worry about that? See, question here is you should understand most of the COVID-19 patients, the
Hmm.
lung pathology is so clear. The most predominant accepted one is more towards the arterial thrombosis.
Hmm. Hmm.
So lung compliance is good. Whether you use with probably the OT ventilators or use with the back squeezer which are being manufactured by the different companies, it's fair enough.
Okay. Okay, sir. So next question is around sir COVID virus again.
Hmm.
How is it different than the H1N1 virus which we saw? And I think statistically it infected many, but then there got a cure. So how different is the H1 COVID-19? Because people are saying there will be a second wave and probably it will always be there with people in seasonal kind of an effect. What is your thought, sir, on this?
Deepesh, you heard of malaria?
Yes, sir, I have heard of it, and I think it's the biggest killer in today's terms for India as
So
well.
since how many years have been hearing about that one?
I understand. Okay.
So the question here is, what are COVID-19 you are saying? 2, 3 years it will go on and all those things. Mutation might happen this way, or we might develop some influenza vaccine and all those things. See, with the influenza or H1, this thing, whatever you are saying, or COVID-19, the
Hmm.
biggest thing is about that one. No? All the time, wherever the disease is manifesting, like smallpox, I was saying,
Hmm.
it's fine. Quarantine was possible. Where it was not, where somebody is carrier
Hmm.
and the benefit not obvious, then it's going to spread. The whole thing about COVID-19 is highly infective, but not less mortality. Compared to Ebola, which has got less infectivity, 50% mortality.
Hmm. Hmm.
Which one you want?
I think I don't want anything, but
Ah,
but yes, if there needs to be a choice,
but
yeah,
look at the positive side. Opportunities to
correct,
improve yourself.
correct.
Is there anything wrong about self distancing?
Hmm, hmm, hmm.
What do you
No,
say?
there is no such
Is
thing.
there anything wrong about wearing mask?
I think it's for our own benefit. We should do that.
Is there
Yes,
anything wrong about hand sanitization?
that's the basic. Everybody should
But
do it. Whether
what's wrong about this pandemic? It is correcting you.
sir, it is improving us as a human
Yeah,
being.
so
Yes.
it is better. You respect. You respect. See, it respect. But don't think it's this penalty. There is no need to pay penalty. But
Yes.
when we don't learn,
Yeah.
somebody is going to penalize us.
I think it's Mother Nature who is
Absolutely, that's the only
ruling
mother nature
us.
who is improved. You know about the clips and all, but I did not put those things because I thought probably my slides were too long, so I
Mhm.
never wanted to put a single picture on my slide also. I'm sorry for that one. For the question.
No, great, actually, sir. I understood your point. We don't have a choice. We have to improve and probably uh, see what the guidelines are saying for our own benefits. The more fast we choose to adopt, probably it is for our own benefit, I guess. You are right, sir. Sir, next question is around air conditioning. You also posed a question to Dr. Peng. For smaller setups, is there any alternative in ICU where there is no
See,
possibility
the
of
whole
negative?
discussion of smaller setup only. There is nothing to do with the bigger setups. Bigger setups can afford. If I got 10 theaters, I can spare 2 theaters only for COVID work.
Right.
It's
But
bigger theaters not a big issue at all. The question is smaller. I look at
small.
smaller theaters. See, we
Hmm.
call it as community responsibility. What we are doing and all. See, one thing I'm very clear about that particular thing is, as per this thing is, if you have the test to clear, somebody
Hmm.
code positive or negative,
Hmm.
you do it. Negative, take it like what did HPC says, you take it up.
Okay.
In case you say that I don't have test and all, you treat everybody as positive. The way you did HPC, needle
Hmm.
prick injuries and all.
Hmm. Hmm.
Simple.
Hmm.
So what your theaters you got, what you can do is induce 20 minutes you wait,
Hmm. Hmm.
then surgical team walk in to the procedure, they'll get out, extubate, 20 minutes you wait, shift the patient out, let them clean and take
Clean
it
them.
up.
Hmm. Hmm.
You might have slow down for 6 months.
Hmm. Hmm. Hmm.
Deeptesh,
Yes.
tell me, last 2 months did you slow down or were you still fast?
Uh, I'm not sure, sir, but I think my life has
50%?
slowed down. Yeah. Yeah. Yeah.
50%? I'm not saying zero.
Yeah. Yeah. No,
So
it's not zero.
same thing next 3 to 6 months, we might have to probably see people may not come to hospital for elective work.
Hmm. 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 Correct. It will be all for compulsory.
So they will wait for some time, things settle down. That's a natural waiting period. That's fair enough.
Fair
That's fair.
enough.
That's given time.
Okay.
Live for the day. Next day will be new beginning.
Hmm. Hmm. Hmm.
Don't have to rush through all the list and no. All the emergencies that had to be done is being done. Whatever the probably stroke patient need to be done is being attended. There is no history of. Tell me one thing, Dipesh.
Yes, sir.
How many people have died because of stroke because the doctor was not available?
I think if it is not reported within first 30 minutes, that's
No,
what I
so
heard.
I'm asking
Hmm.
about 24th or this 24th, about last 50 days.
Okay, sir, I'm not aware of the news of this kind, but I believe it is
I'm not
less,
aware, not
less,
aware.
less.
How
Yeah,
about I had a heart attack, nobody attended me.
yeah.
Next to nil. I'm not saying.
I think yeah, not reported much.
But
Yes,
obstetrics, there was people delivered on the road or maybe in the vehicle and here
yes,
and there, right?
yes,
And there are people
yes.
who died on the road while walking back to their territory.
So, sir, are you suggesting that if we follow the normal slowed down version of our lives,
Yes.
are
Yes,
we going
yes.
to?
But question here is, whatever has to happen, despite all these things, everything is going to settle down. Take care of the
Okay,
pregnant women because pregnancy is something framed. 9 months, no delivery, it has to happen. It has to happen. People walking on the street and all this and dehydration and food and lack of those things are going to be there that we have addressed. So there is no medical emergency at this stage of push yourself for too much thing except for pregnancy and maybe trauma. Now that we opened the road and all, everybody is bang, 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 bang. Those things, the trauma is going to be there. The stroke might come because of the old age, right? And the
hmm,
fall. Like you may get hip fractures.
Mm-hmm. Okay.
Age is going to continue. Hip fractures, stroke, and these things. Of course, you will get the MI incidence more henceforth because somebody had a business loss.
Okay.
So
So
those, so
that's
you
why.
have to accept things. See, pregnancy and related,
Mm,
walking, dehydration and all, and the trauma at home, somebody fell
mm.
down, and stroke because aging process. Those things are going to be there anyway.
Okay. Sir, we have only two more questions from our audience which are left.
Great.
I think the question is probably as an anesthetist to you. How are you managing anesthesia in remote locations of the hospitals like cath lab, endoscopy, radiology units? Is it in practice now?
No, see, of course, it's very clear. It's very clear. But I think that makes sense. Whatever because Asper is asked and all, respect their thoughts and all.
Hmm.
And see, the question is simple thing. If your hospital has the the lab test to confirm whatever the COVID test, like you got two tests, you got about a polymerase chain reaction, like RT-PCR is one, tells about virus presence. Next, antibodies. So virus you have it or not, and antibodies itself whether you had a virus infection last a few days or whatever, IgM or IgG. In case you have patient all those things, if you have that particular thing and all, RT-PCR test, if it's positive, you know what exactly you have to do. But it's emergency, this thing. At the end of the day, if you have a positive result and clear-cut ideas, if you want to postpone, you can postpone if it's possible. Otherwise, you take it as an emergency and take all precautions. If you cannot postpone, every patient you have to take it up. The simple is an emergency thing. That's a consent what you get in this pandemic, and take the precautions and then go about it. If it's not emergency, postpone. Simple.
Okay. So last one is actually a discussion from your side. People are asking, how shall we go forward if this lockdown ends? And as an anesthetist and as a fellow countryman and clinician, every aspect, what is your suggestions for all of us, sir?
No, my suggestion, my thought to all my colleagues and all, not that I am different and they are something different and all those things. I think it's difficult. See, institutions, it's not a problem. Especially, I am worried about the freelancing practitioners and all. Like somebody says, I have posted so and so. The biggest challenge for us is two things. One is PPE not testing not available. Yes or no? First and foremost thing.
Yes, testing kits are limited.
Only not limited. PPE not available.
Yes, people are struggling to
So
get that.
basically, you are sending a soldier to the battle that we don't know who is the enemy and we can't provide the gun, but you go and fight. What do you expect him to do?
Mm-hmm.
Ritesh, you got me?
So I understood. Yeah, that's
See, the
situation.
nation doesn't provide a testing kit to tell who is the enemy and
Mhm.
doesn't get PPE kit, weapons, and but you say you run the hospital.
It's very difficult.
But it's not with only our country. It's across the globe.
Mhm.
I don't say it's only our country. It's across the globe. So the challenge here is what we have to understand is who is that? How many people really require surgery? Say, like I told, the colleagues are there. The for example, the pregnancy with the due birth, what needs to be done. This thing needs to be addressed. There's no other option. But when you're doing any of this patient, you presume everybody is positive. Everybody, in case you don't have resources, send them to nearest center where they can do that.
Sir, we lost
It's
your
not
voice.
worth
Yeah.
risking our healthcare professionals. Because see, for one case you might be heroic, you might do and all, but subsequently that particular Taluk headquarters hospital might be quarantined for 14 to 28 days. All healthcare people that get shut down, and so many patients will suffer just because of one patient where we are emotional about it. But it's across the globe. Nothing special about India.
Correct. So, sir, now questions are over from my side. I believe you can all guide us to.
Uh, I know. I'm just thinking whether I finish all my questions, whatever things. I think
Please,
most of
please.
the things.
We have covered. Yes, we have covered. I have
I
seen
think
it.
you're Diptesh. See, but what I say, Diptesh, clearly, if I were to be you as a common man, is it what I'm trying to say?
Right.
If it's not required, telemedicine we have to utilize. But telemedicine cannot be substitution for all the things because you cannot cook food by just watching TV or maybe software on the computer or maybe on iPad. Am I right?
Right. Right.
Things are so easy. There are no need for mother.
Mm, mm.
Can you get motherhood by watching any of the iPad or iPhone, something like that?
Absolutely no. Yeah.
Mother is mother. So
Correct.
same thing here, but at this thing, I think all of us we have to buy. See, that's where I spoke about history before I spoke anything. I think I'm sorry for Diptesh about the font being small, not because anything like little bit probably I should say about the thing, but when that was history. History you can always hear. Like I don't put probably like what I should say about the PowerPoint kind of thing. This thing, but that's okay. But history people have heard. You had when see it has taken 2 to 3 years for every pandemic. At
Mm-hmm.
least flu point of view, we have to be ready for that one.
Correct.
Make sure live for one more day. Take care of your personnel at home, at hospital, and make sure they're comfortable.
Correct.
And take patients and all, and the patients are not in a hurry to come for surgery once they know that about what's happening around them.
Mm-hmm.
So they will also slow down, and maybe 6 months we'll have solution for all these things. That one is the best of things. It will settle down.
Correct. Correct.
It will settle down because the question here is somebody who's hungry, you're trying to snatch his food and trying to give to somebody who is not so hungry just to make. So somebody who requires probably COVID-19, probably the RT-PCR for their survival kind of thing, and picking and then they're trying to use that for some patient with tooth extraction. So that's where the whole dilemma comes.
Correct. So we have to be positive and
It will,
probably
it will
take one
happen.
day. Yeah.
It will happen. It will settle down. It will
Okay.
settle down.
Okay. So, sir, I have come to my end of this whole question and answer. Over to you now. You can guide me how to take it up. And
No,
if you,
it's fine. It's fine. So I'm happy about about discussion and all. All we can have it as required and all those things. And we have to respect people and all. And every country has its own commitments and responsibilities and things how it has to go on, how many kits are available, where they want to utilize, and funding and all. It's very easy. Sitting in probably in a comfort zone, we can ask, and the government has its own difficulties. But the only we can tell is the two things, especially on a 3 point of view. If you have the facility for that getting tested and all those things, you get the testing done. Testing is negative, go ahead with surgery like routine, whatever you would have done. If it's testing says like a positive, wait for whatever the duration of the quarantine the country says. In case at the end of the day you don't have testing and all, treat everybody as clinically positive, and in case you got enough PPE to take care of all your personally, you go ahead about the whole work. As simple as that.
right, right.
It will be fair enough. Everything will be fine, Diptesh. It will be fine. Probably yes,
That's
now near the electric down. We'll have one more for saying thanks to everyone.
correct. Thank you so much, sir. Thank you so much, first, not only for your time, but for your valuable discussions that we had. We had discussions at
We
length.
learn from each other, Diptesh. We learn each other.
Correct, correct. Thank you so much for your time. And everyone, thank you for attending the session. I hope you all liked it. The recording is there on our website and YouTube right away, right now on our YouTube channel. And thank you again. Many, many thanks to Dr. Joshi for his time.
Thank you so much. Thank you, everyone.
Thank you.
Thanks a lot.
Thank you.
Bye-bye.
Bye bye.
Bye.
Bye bye.